postoperative complication. And what do you need to be a kidney transplanter, and why you need to be a transplantation specialist. I will start by the final question, why you need to be a transplantation specialist. In my opinion, you should know your why in life. Before starting any educational process, you should know your why and put it in your mind and thinking about it every day before any education. Because this why will drive you to be a good person. First of all, we have patient who is in suffering in hemodialysis. If you wanted to be a transplanter for him, so be it, or you want to be a great doctor, it's your decision, but you should decide your why and why you need to be a transplanter. This is a very important question. Kidney transplantation. What is the principle of kidney transplantation? It is that simple. Patient with renal failure or a CKD patient with non-functioning kidneys, you just put a new kidney in his body and he will be a normal person again. Why it wasn't that simple? Firstly, the science of transplantation is based on immunology, and the immunosuppressive medication upgrading, it's a cornerstone for successful kidney transplantation. First kidney transplantation was done in 1954. This is a day in history. So we should, what we should do to evaluate a kidney recipient. This is our patient. What do you think from this picture? This patient is old. This patient having a kidney failure, and he is on hemodialysis. This is from this picture. This is our patient. So there's a staging of chronic kidney disease. This is as the item from the book. He talk about the measurement of GFR. First of all, GFR is measured by clearance of ideal filtration marker such as inulin or radioactive iodine, radioactive material, for estimation of GFR. This is not what we do in clinical life. In clinical life, we estimate, not measure. We use a creatinine clearance or equation like Cockcroft, MDRD, and CKD epidemiology. And these equations still have no powerful base evidence and they need more cohort study. So when we talk about CKD patient, CKD stage 5, GFR below 15, we're talking about estimated GFR, not measured in GFR, because we not in clinical practice do measured GFR in routine basis. This is the usual table for the stages of CKD, stage 1 and the stage 2 and the stage 3, which is divided to stage 3A and the stage 3B and the stage 4 and the stage 5. And we are talking about this group of patient. I will take the mouse to present. Yes, this group of patients. We are talking about staging 5. Okay. Okay. So this is from the book. How to evaluate a kidney transplant recipient or patient. There is a title in the book called The Demographic of the End-Stage Kidney Disease. Sorry, I will try to make it closer for the person who read the book. So I will take some parts of the book and publish it in the PDF to just remind you when you read the book, you don't feel there is something different. This is a title called Demographic of the End-Stage Kidney Disease Population. We will take this title and put it under the our patient recipient. This is our recipient. He will talk that about most of end-stage renal diseases are diabetic and hypertensive and atherosclerotic and poor patients. So when you read this topic, you should put in mind this is not this is your patient now. This is the recipient. The end stage renal disease. Now it's called the patient recipient. Okay. So this uh, important information. He will talk about congestive heart failure and the prevalence of renal patient. It's present in 35%. It's a very huge figure. Whereas coronary heart disease is found around 40%. This is two large figures. Around half of your patient in hemodialysis or CKD stage 5, they have a huge cardiac disease. Some are congestive heart failure and some of have a coronary heart disease. So when you get a patient in hemodialysis and he asking you to transplant him, you should think about all of this. You should think about his cardiological evaluation and put in your mind that half of your patient are cardiac and have coronary heart disease or ischemic heart disease. And put in your mind also that a patient, your patient in hemodialysis, and it's all complication of hemodialysis on him. He has a vascular access, which may have aneurysm or impending rupture or infection or Maharkar or associated with infective endocarditis. He has anemia. He has tertiary hyperpara or secondary hyperpara and atherosclerosis and so on. So it's not only the immunology what matters. Your patient, you should know your patient is not a classic patient. He is have multiple diseases. Also, infection matters. Our patient mostly have HCV, and when you think that patient wanted to be transplanted, you should think of treatment his infection. Malignancies. You will surprise when you know that our patient in hemodialysis has 2.5% increase in malignancies than general population. So he may have a malignancy, primary kidney disease. What is the meaning of primary kidney disease? I will show you a table of the kidney diseases which recur after transplantation. So here in the table, the patient come to us as an end-stage renal disease, and we don't know what is his primary kidney disease. So we should exclude diseases which recur after transplantation, like FSGS, primary sclerosis, atypical HUS, and so on. One moment, clear. Okay. So again, we have a patient in hemodialysis or CKD stage 5 and asking you for doing a transplantation. And most of us are just thinking about his immunology. And again, I want to focus that your patient have a cardiological disease and he is on hemodialysis, have infection or maybe malignancies. His primary kidney disease, we don't know. And if we know, is his primary kidney disease is able to recur after transplantation or not. And in schedule immunology here is its place. It's not the first one, because most of our candidates, young candidates, when a patient ask him for transplantation, he will do APO system, HLA typing, and this is wrong. You should evaluate your patient first. You don't think in immunology at the first step. You should think about the previous important things. Vascular problem, because when we do a transplantation, we need good vessels to anastomose. We need a urological evaluation, because if For example, patient have autosomal dominant polycystic kidney disease with large kidneys, there will be a urological problem here. If the patient has a vesicular reteric reflux, you will have a urological problem here. So it's important to think about a urological evaluation of your recipient. Again, this is our patient. Our patient now, he is old, he is mostly diabetic or hypertensive, he mostly have a cardiac disease, he may have infection, may have malignancies, may have a urological problem, may have a vascular problem. All of this must be evaluated in extra to the immunology evaluation. Different issue here when we talk about living donor evaluation. Look at this young lady. This is an example for a donor. It's fully different from our patient. She is young, she is healthy, and she asking you to donate. And when you are in this situation, what is the most thing you should consider? You should consider that risk of developing end-stage renal disease. You should exclude this young lady will exposed to the risk of developing end-stage renal disease. So when you evaluate her, you should exclude diabetes, proteinuria, positive family history of kidney disease, and I will put example for this right now. Stone Balser, urological evaluation. Uh, for this, now if the urological evaluation may be cause of end-stage renal disease, we don't evaluate for putting a new kidney. This is a different angle of view. When you look to the donor, when you do a urological evaluation, you should exclude there is no stones, no reflux. This could precipitate end-stage for him. You should do a psychological evaluation. There is no force for donation. His cardiac evaluation, and here cardiac evaluation is much different from the recipient. She has no cardiac risk, so just echo and ECG could be enough. But our patient, which is end-stage renal disease, no, it's different issue. You should do a very strong cardiac evaluation than the recipient, than the donor. And finally, the quality of the graft, which is usually done by isotope scan. And the last step is blood supply. Uh, there is an example for the a patient with polycystic kidney disease, and his sister or his brother asking you to donate. And this is occur a lot. So here we are. We have patient with autosomal dominant, and we have a sister or brother with positive family history that they have an autosomal dominant kidney disease, and she wanted to donate. And the most important question you're asking yourself: is this donor is liable to develop in this autosomal dominant polycystic kidney, and he will be also an end-stage renal disease or not? And this is a big issue. And when you look to the table, you found that if you have a patient young, below 30, so you should do ultrasound and MRI and the genetic study. But if your patient is older than 30 and below 40, you should do ultrasound and MRI only. There is no need for genetic study. But if your donor is above 40 years and the ultrasound is normal, so you can donate for directly, and there is no need for further investigation. So again, when you have a donor and a normal person, and he asking you to be a donor, you should tell him about the complication. And this is a table shows a complication post-operative, and you should put in mind, and the most common complication after nephrectomy is hemothorax, because we do a nephrectomy, and the surgeon may cut the diaphragm, and the patient show high hemothorax. Okay. Again, this is our donor. I will share with you in clinical practice what we do. When we have this young lady is coming to you in the clinic and asking you for donate, first of all, we should exclude risk of developing end-stage renal disease. We asking her about diabetes. We asking her about hypertension. We exclude proteinuria. We do ultrasound to show the anatomy of the kidneys. We do echo and chest X-ray and ultrasound in the beginning, then plenty IVB to exclude any stones in the any urological abnormality. Then we evaluate the graft by isotope, and the final step is multi-slice CT angio to evaluate the kidneys blood supply for the surgeon. The order of your requests must be considered. Isotope, it's the pre-last, and the CT angio is the last step, because if you decide to take this donor and accept him, there is no diabetes, there is no hypertension, and the immunological is suitable for the recipient, and ultrasound is good, brand IVB, there is no stones, and isotope, the function of post-graft is good. So the CT angio, it just will be for the surgeon, because the whole idea of CT angio, how you will find if these kidneys have one blood supply, two blood supplies. This is the last step. Don't rush to put all your investigations at the first. Your investigations should be step by step. Start by evaluation of her diabetes, hypertension, infections, ultrasound, the basic routine investigation before rush to immunology, and before rush to do isotope scan to evaluate the graft, and finally don't rush to do a CT angio for the evaluation of the blood vessels, because it's a very last of the session. And this is the operation. It is very simple. We open a incision, and we make something called a bed for the kidneys, and we put a kidney here in the pelvis, and we anastomose its blood vessels and the ureter to the bladder, and it's finished. You have a kidney full functioning for the patient. Again, post-operative complication, there is two groups of complication: early complication and late complication. And this is from the book. Again, when the book divide the complication to two groups, early group and late group, this is from a vision. When we have a complication in the first 3 months, this is what's called early. Mostly it's related to surgical complication. And after surgical complication, it's mostly due to rejection and mostly to the immunosuppression. But this is number one. So early complication, mostly surgical. Late complication, surgical is too far to be the cause of graft dysfunction. And it's mostly related to immunosuppression and rejection and infection. So infection is more common at late, malignancies are late, but surgical complications are more at early. If we have questions or we have to have a discussion, we just raise your hand, and I will write your answers, questions in the chat, and I will look it. Okay. This is a question here. What you will do if you have a dysfunction graft after kidney transplantation? Put yourself in the shoes, and if you have a patient, just do a transplantation just a couple of hours, and the doctor and the physician in the center of KTU just tell you that the graft is not functioning. What you will do? It's better to communicate. If you have someone has the answers and he wanted to share with us, just raise your hand or write your answer in the chat. Okay. Depend on living. What do you mean by depend on living? Just to communicate, I want to hear from the participant what you will do if you have a graft dysfunction after a kidney transplantation. Just a couple of hours. Ultrasound. Okay. Doppler. Excellent. Biopsy. This is what I want to concentrate on. First of all, Doppler and ultrasound, it exclude surgical causes. A science of medicine, it's a science of wisdom. So when you have a non-function graft, and you just did operation just a couple of hours before, you should exclude any surgical complication. And as this is done in the real life, you just do Doppler and ultrasound. Doppler and ultrasound will show you any surgical complication. And if the ultrasound and the Doppler is good, you feel relieved because there is no surgical complication. And after this, as you mentioned, you should think about the fluid status, because the most common cause is ATN or pre-renal. And in the final, we do, there is two things we do almost. We do a tacrolimus level, especially when the patient started immunosuppression early. And we do what is called post-transplantation cross-match CDC-DDT to detect early antibody, de novo antibodies post-transplant, and finally as a kidney biopsy. When you read the guidelines about not dysfunction graft after kidney transplantation, you will find you can wait from 5 to 7 days until you do kidney biopsy. And this is wise, because if you have who just have a very long ischemia time, and you have this patient have good immunology and have no risk of rejection, and he has full covered of immunosuppression, you will exclude that he should have he maybe have a rejection, and you will mostly suggest that he have some kind of ETN or something like this. So it's biopsy in clinical life is not the first option you think about. You will you should think about the like the participant said. You should think about ultrasound. You should think about Doppler and tacrolimus level and cross-match CDC-DDT if you think that patient may have the risk of rejection, and finally biopsy, not the first option as most of us think. So what we will talk about again post-operative complication. I will just also ask the participant what do you think patient of end stage of transplantation die from? Sorry, it's kidney transplantation. What do you think patient of kidney transplantation die from? I wanted to share from the participant. Just write in the chat. Okay, infection. Infection. Most of all thinking about the infection is the most common cause of death. Wow, cardiovascular. This is right. Yes, this is right. I will share this slide with you. Yes, this is it. Our patient of kidney transplantation, 37% died due to cardiovascular disease. 37% dying from cardiovascular disease, not infection. Infection is the second one. And there is in the causes of mortality in renal transplantation is rejection. So rejection doesn't cause mortality. Cardiovascular disease and infection and the risk of malignancy is the third one. Okay, this is an important table. Don't forget, infection is important for transplantation, but cardiovascular disease is much important. This is a breaking news, as I mentioned. Every session we see information outside the book, outside the agenda. We now we will study what is called hierarchy of evidence. What do you mean by this? Here we go. Any medical information should have evidence, and this is the evidence of this is the evidence. We have case report. What do you mean of a case report? Someone puts information about a case he find in his hospital. Case control study. This is a very weak evidence. After this, we have a case control study. What do you mean by case control study? We have a patient, and we have a normal population, and we do a comparison. We have a case, and we have control. And this is if we have very group, small group called case control study, and if it's very large group, it's called cohort study. So both of them are non-experimental. It's just observational study. You should all what you do, just have a patient and you have a control and you do a comparison and look, it's observational, not experimental. And the most important one is experimental. Experimental, you like giving a drug, and some people have taken the drug and others didn't take the drug, and you show the result. This is the most important and the more evidence data in the medicine, especially when it's randomized. You have no selection of your patient, and this is the experiment. When you have multiple studies and you do analysis, this is called meta-analysis. Meta-analysis is the multiple studies. Some of them are observational and some of them are experimental, and experimental is more evidence than observational. And in the final, we have a clinical practice guidelines. So again, this is the hierarchy of the evidence in the medicine. You should know this. We have observational and we have experimental. Observational, you do nothing. You just have a case and you have a control and do a comparison. It's observational. Experimental, you give an insult and you start to compare compare after the insult. So you experiment, and this is a very strong evidence. When you do a meta-analysis or analysis of these studies, so it's called the meta-analysis, and then finally you have the clinical guidelines. This is a very important slide. You should consider what do I mean by evidence to be. You all the time hear this word that anemia treatment with is a therapy has evidence 2B, 2A, whatever. What does this mean? Maybe we can share in the chat if you want. What is the meaning of this evidence 2B, whatever? Just write in the chat. Okay. There is no one. No one know what is the meaning of evidence 2B or 1A or 1C. Okay, I will see it. 1 and 2, it's from the expert. We get all the expert in the transplantation specialty, and they ask them about treatment of antibody-mediated rejection, treatment with IVIG. So if the all expert make one opinion that IVIG have role in treatment of antibody-mediated rejection, this is level 1A. If it is level 1, level 1 and level 2, it's related to expert. Expert make a decision. If the expert have one decision, so the level is 1. So what does it mean? We recommend level 2. If some of them are agree and some other not agree, this is the evidence become we suggest. And the level 1 B, A, B, C, D, it's related to the studies. So we have experts and we have studies and the quality of the studies. So if we have evidence 1A, if you did something different from these guidelines, you may have a medical legal issue. And if you have level 2C, you have a strong evidence that you can do whatever you want. To understand this more, I will show you the guidelines of cardiology, which make it more easier than nephrology. They have it in colors. Class 1, it's a green color. You should do it. Class 3, you shouldn't do it. If you do it, you have a medical legal issue. You may go to the prison. Class 2, whatever the color, it's yellow. You can do it, or can you do it? And this is very important because when we talk about the evidence in the transplantation, you should know what is the meaning of 1A, 2B, 2C, because most of studies in transplantation have a very weak evidence. Okay, yes, so it's related to experts and related to the studies. This is the first chapter in the book, which is called Option for Patient with Advanced Kidney Disease. And we have what is called renal replacement therapy, which is 3. First of all, hemodialysis. 2, peritoneal dialysis. 3, transplantation, as we mentioned. So we have 3 options. No more. Hemodialysis. It's the most popular modality ever. I just wanted to ask why hemodialysis is the most popular modality. You can answer from the chat also. We have 2 minutes. Why hemodialysis is the most popular modality? What do you think? Okay. Easy available. يا شيل الشخبطة اللي مضايقكم. Available less expense, emergency. Excellent. That's emergency. Emergency, this is the first one. In some period, the peritoneal dialysis was the first option, and it was the most popular because of acute peritoneal dialysis, and there was established facilities in everywhere for peritoneal dialysis. If you have most of our patients presented with acute or chronic CKD need urgent dialysis. So in this while, the peritoneal catheter, acute peritoneal catheter was inserted, and the patient to start acute peritoneal dialysis and then continue on peritoneal dialysis. But now, because of the update in the Maharker, and we have available acute access for hemodialysis, the hemodialysis started to be the most popular, and we have established the facility. When you want to start hemodialysis, you can start it anytime. And now we have centers, nurses, water treatment therapy. So everything is established for hemodialysis. So it's become the most popular. First of all, because it's well functioning at the emergencies. This is the most powerful point in the hemodialysis, and then the established facilities from the nurses to water treatment to the doctors to dialysis centers. This is also all of them are available. So this is why hemodialysis is the most popular modality. What is the principle of hemodialysis? Hemodialysis is depending on solute removal by diffusion across a semi-permeable membrane within a dialyzer or artificial kidney from a blood circulating through an extracorporeal system. So we have a vascular access, and we take the blood. The blood goes through a dialyzer or artificial kidney, which clears the solutes, and the blood come back for the patient. This is the principle of hemodialysis. What is its advantage? The advantage, as we mentioned, it's it can be used in emergencies. It's established the facility. It's well functioning, and the patient can tolerate it. What is the disadvantage of hemodialysis, which is very important? First of all, patient receive 12-hour to 15-hour per week. We have most of patient has 3 sessions per week, sessions from 4 hour to 5 hour maximum. So we have 12-hour or 15-hour. We have per week 165 hours. So 860 hours. So the patient dialyzes for almost 10% of his life. And if we have a patient, we have 153 hours without dialysis. There is a big disadvantage. We have a very big cardiac issue, as we mentioned, because our patient from the start is anemic and diabetic and hypertensive and atherosclerotic. I want to ask 2 questions here before I continue about anemia and the cardiac stunning. First of all, anemia. What is the target hemoglobin for our patients, and what is the definition of anemia? Just participate in the chat. Anemia, target hemoglobin is 11, 10.5, 11.5, 11, 10, 12. Just revise the guidelines, please. When you read the guidelines for treatment of anemia in CKD patient or end-stage renal disease patient, you will find what is called individualized medicine. What is the meaning of the individualized medicine? General population, your target is from 10 to 12, as you mentioned, all of you. But you should know that the definition of anemia didn't change. Your patient is still anemic, and he may have risk of heart, he may have poor quality of life, and etc. So the target for general population is, as you mentioned, from 10 to 12. You just revise the guidelines. You will find it. I will show you in the WhatsApp group. The guidelines there is a very small line. What's called individualized. Or what is the meaning of the individualized? You should know that your patient is still anemic, and if your patient has symptoms of anemia, or if he has chest disease, heart disease, and they have poor quality of life, you should evaluate the benefits against the risks about increasing the hemoglobin above 12, because this is associated with more cardiovascular disease and mortality. But if you increase the target, you will may get benefits, but you may get also disadvantaged. So this is number 1. Number 2, I wanted to ask about the cardiac stunning. What is the meaning of cardiac stunning? What does it mean about the cardiac stunning? Okay, I will say it for the lack of time. Cardiac stunning, when you search for it, it's non-obstructive ischemic heart disease. Yeah, if patient has normal coronaries. Patient has normal coronaries. There is no bad bad coronaries, and he has ischemic heart disease. And this is strange uh, because our patient must have interdialytic with gain, and when he comes to the next session, you should do ultrafiltration. You sometimes exceed your target, and the patient have suffer from intradialytic hypotension, or may not. But when they do an echo in the hemodialysis patient during the session, they show that the heart show signs of ischemia during sessions due to the hemodynamic instability, which is maybe silent or maybe presented, as we mentioned, as we see in our patient, they have chest pain during the sessions. And when they do a PCI, there is nothing wrong in their coronaries. And this is what called cardiac stunning. And this is related to hemodialysis patient. I want to share this information with you. Okay, there is number one, anemia, and as we mentioned, and number two, we was talking about the cardiac stunning, which, as we mentioned, it's non-obstructive ischemic cardiomyopathy or ischemic changes for the heart of the patient occur during the sessions associated with ultrafiltration. Quality of life, and this is a big issue in the hemodialysis patient, because our patients are stuck to bed for 3 times per week, and they should go to the hospital. And there is a very important issue in the quality of life. I want to share it also with you. Something called dialysis recovery time. Do anyone know about dialysis recovery time? What does this mean? You can share it also on the chat. Sorry, I need to all of us to communicate. It's not a presentation, it's a communication. So we asking here about what is called dialysis recovery time. What do you know? What do you know about this item? Anyone? Dialysis recovery time. Okay, I will say it.
Hello.
Our patient, after the session, they feel fatigue, they feel myalgia, and this lasts for around from 2 hours to 6 hours, maximum for 12 hours after the session. And this is what's called dialysis related recovery time. This is the time needed to be recovered after the session. So this is an important issue you should study, and this is have a great effect on this of the patient. Your patient come to the session, and after he finished the session, he feel fatigue, and which is last for 12 hours after the session. So he will suffer in the session and after the session. So he have a very low quality of life. Number three, it's disadvantage. To need to do a hemodialysis, you need a good vascular access, and the vascular access complication are common, and which have a great impact on the quality of life and the survival of our patient. And which is noted for all of you, CKD, MPT, and uremic neuropathy, and finally malignancy. The peritoneal dialysis. What is the principle of peritoneal dialysis? The principle of peritoneal dialysis, we use peritoneum as a dialyzer. So solute removal and ultrafiltration is achieved using the peritoneal dialysate, and the peritoneal membrane acting as a functional semi-permeable membrane for the dialysis. Efficacy of removal of the solute. Kindly stop writing on the. Okay. Small solute is relatively low compared to hemodialysis, but the removal or clearance of high molecular weight solutes is somehow better. So peritoneal dialysis, it's a modality from peritoneal hemodialysis. We use the peritoneum as a membrane for removal of toxins and ultrafiltration, and to do ultrafiltration. Okay. What is the advantage and what is the disadvantage of the peritoneal dialysis, and why it's not so popular? And the answer, as we mentioned before, it's emergency. It's very aggressive to insert acute peritoneal catheter, and it's not fully easy to use it in the emergencies, and it's not have an established process. The solutions become expensive because it's few to ask, so it's become more expensive, and they become less popular than hemodialysis. It's the advantage, it's better in quality of life. The dialysis is not, as we mentioned, 15 hours per week. It's almost all the day. So you have better dialysis, and you have better in the element of cardiovascular, because there is no intradialytic weight gain, and intradialytic weight gain and hypotension, and etc. Disadvantage. When we talk about the disadvantage of peritoneal dialysis, we all think about peritonitis. Peritonitis and infection in peritoneal dialysis is the most disadvantage of it, and the recurrence of peritonitis lead to failure of the membrane, and we lose the peritoneal capacity of removal of the toxins, and finally the patient have to shift to hemodialysis. Finally, we have transplantation. And the principle, as we mentioned, of transplantation is just to put a kidney in a patient who is non-functioning kidney, and he will be a normal person again. Its advantage and disadvantage. The advantage of transplantation is all the disadvantage of hemodialysis. I will just put a comparison to get the idea. Hemodialysis patient is anemic. The patient has atherosclerosis, calcifluxes, vascular calcification, interdialytic weight gain, interdialytic hypotension, cardiac stunning, and etc. This is not occurs in transplantation. So the cardiac-wise in transplantation is better. Quality of life, of course, it's better in transplantation. This patient are not attached to a session. There is no dialysis recovery time. There is better hemoglobin. This is all of this factor. There is no autonomic neuropathy or uromic neuropathy, and etc. There is no CKD MPD. There is no anemia. There is no need for vascular access. There is no neuropathy, and the most important two issues: malignancies and infection. What do you think about malignancies? Who is more common, malignancies in transplantation or malignancies in hemodialysis? Uh, we can share and we can communicate in the chat. What is more common, malignancy in hemodialysis or malignancy in transplantation? Okay, transplantation, ETG is very smart. Transplantation, all of them, transplantation. There is an definition, what's called the preemptive transplantation. Preemptive transplantation, that means your patient, when he CKD stage 5, you transplant him before going to dialysis. And this is the powerful of transplantation. If you do it, it's better because you will avoid all the previous ones. If the patient continue in hemodialysis for a long duration, he will have a cardiac wise and the quality of life and CKD, MPD, and anemia. Some of them are fully reversible after transplantation, and some of them not fully reversible after transplantation. So it is better to do a preemptive transplantation, and the extent of preemptive transplantation is up to 6 months after dialysis. So if you have a patient on dialysis just for 6 months, it's called, and you transplant him, it's called preemptive transplantation, because there is no risk limited risk for exposure to the previous ones. And I will share this slide with you. This is the risk of malignancy in hemodialysis patient and dialysis. And here is the number. The risk of transplantation is 2.7 and dialysis is 2.2, 2.6. It's almost the same figure. And this is published in Australian registry, and this is the number of the patient. It's a very huge number. So it's a very strong study, which shows that the malignancies in transplantation and dialysis almost equal. And the most common malignancies with dialysis is the kidney and testicular and the multiple myeloma and the transplantation skin malignancies and non-Hodgkin lymphomas and kidneys. Both of them are still higher than general population, but dialysis and transplantation almost is the same. And the final item in the comparison of transplantation and the hemodialysis will be the infection. I will show you this review study, which published also in New Journal of Medicine. This is published by our professor Muhammad Nasrallah. Is a very bigger as usual, and he asked about transplantation in the era of the COVID pandemic, and I share it in the WhatsApp group, and I will share it again. And he have multiple questions. I will share it with you. First question: does the disease present differently in the transplantation patient recipient? And if you have a transplant recipient and he catch a COVID, do you think that the presentation will be more exaggerated or less than general population? What do you think? Just share it in the WhatsApp, in the chat. Okay. Who will have less or more? Less or more? How when you read the review, you'll find something unusual. The presentation is less than general population, which is strange, very strange. Our patient have immunosuppression and already on steroids, and the cytokine storm, which usually have the general population, our patients have survived from it. So the presentation is fewer than general population, which is very strange. And it's a very interesting review. You should read it, all of you. And also, he asked how to test and who should to be tested, and does the transplantation population have risk of overt infection and poor outcomes, which the answer was no. And should transplantation be halted, just be stopped during a pandemic or no, which the answer was no. All the humans, does you, if you get a graft from a patient who COVID has a COVID-19, the donor was positive COVID, there is a risk of transmission of COVID to the recipient. And what is how can we deal of immunosuppression during a pandemic? And it's very, very strong review, and you should all of us read it because it's to the point. It's not blah blah review. It's very strong and to the point. And he show in this review two reviews about the Italian Society of Nephrology, and I will share it with you now. The Italian Society of Nephrology, they screened this number of kidney transplant patients and found infection in only this number, 218 patients only who have exposed to positive COVID, and only 54 died. So we have all this number, and we have only this number of infection, and only 25% deaths of cases, of infected cases. And when we do a comparison to two groups, first one was a dialysis patient. He do a screening for this large number of dialysis patient, and there is the confirmed cases, and around 40% of cases died. Around 40% of cases died. So dialysis patients are more exposure to COVID and more bad outcomes in dialysis patient. Whereas the transplantation patient have low exposure and low death rate than dialysis patient. And also comparison to a general population group, as you should read, and this is the French registry data, when they do a screening for this number of recipient, and the confirmed cases was around 80 patient, around patient transplantation, and this large number, and the patient who caught Kokachi infection around 510, and the death rate was 15%. And when compared to the patient in hemodialysis, the number of deaths in hemodialysis was around 30%. So we have 15% in hemodialysis against 30% in transplantation, 15% in transplantation against 30% in hemodialysis. So hemodialysis patients are more liable and more have poor outcome than transplantation patient, which are unusual or unexpected. This is the guidelines, nephrology, dialysis, and the transplantation. And when you read, all patients with end-stage renal disease should be considered for transplantation unless they have an absolute contraindication, because renal transplantation offer life expectancy, بين قوسين less cardiovascular insult, and quality of life, as we mentioned about dialysis recovery time and etc. This is the guidelines, and it's evidence. It's 1E. It's the strongest evidence. All experts decide, and all studies show that transplantation is better than dialysis. At the final, this is our agenda. What is the type of renal replacement therapy? As we mentioned, it's 3 types. What is the advantage and disadvantage of each one? And as we mentioned, is kidney transplantation is the best management of CKD? Yes, especially in era of COVID-19, of course, yes. Immunology and immunosuppression, it's a very important issue, and this is will be the talk of the next session, but it's not the only thing. You should put it in mind. You just remember the picture of our patient, our old patient, and how to evaluate a kidney patient. We should evaluate his heart. We should evaluate his vascular access, hemodialysis complication, all CKD, MPD, infection, malignancies, and immunology. Immunology, it's important, but it's not everything. And it's his primary kidney disease is very important. How to evaluate your kidney donor, and you just remember our young lady, which was normal, which have no diseases, and she just wanted to donate, and you should exclude if she have risk of end-stage renal disease or not. Also, operation, as we mentioned, and the postoperative complication, which is divided to early complication or late complication. What do you know to be? What do you need to be a kidney transplanter? And I will answer it in the next slide. And why you need to be a kidney transplantation specialist? I will ask this question to all of you. What do you need to be a kidney transplanter? Just write in the chat. What do you need to be a kidney transplanter? Good training. Only good training to be a kidney transplanter. Training, knowledge, and the practice. You need a team. You need a team. As we mentioned, to do a kidney transplantation, you should make your own team. you need a cardiologist, urologist, vascular surgeon, immunologist, nephropathologist, radiologist, and finally, the team needs you because you are the maestro of this team. You use a cardiologist when you need it. You use a urologist, immunologist. For immunology, you need a good nephropathologist to look to the biopsies. You need a very strong radiologist to evaluate the ultrasound and the Doppler. And this is our curriculum. First session was about options for patients with kidney disease. And our next session will be around HLA, which is a very important topic, transplantation immunology, and the immunosuppressive donor evaluation, which is divided to two groups, deceased and living, recipient evaluation and operation, early complication, late complication, nephrohistopathology, and the transplantation is special situation like diabetic, hepatic, and the child population. Finally, we'll end with nephroradiology, psychology, and nutrition. This is our curriculum. Our summary: find your why in life. Find your why in life. This is very important. Study hard. Share with us in the meeting. Communicate. And we have Facebook page, Telegram, and WhatsApp. And thank you. If we have any discussions,